Good afternoon, good morning, or good evening, wherever you may be. My name is Ann Brazo. I'm the CEO and founder of MPN Advocacy and Education International. We host many webinars over the course of 12 months and in-person events during the course of a year. And today we're very excited to have Dr. Jennifer Vaughn with us from The Ohio State University. And her topic is just wonderful. We were so excited when she said she wanted to talk about financial toxicity and value-based care. Jennifer sees approximately, over 150 MPN patients at Ohio State, and we're just delighted to have you with us, Jennifer. So I'm going to turn it over to Dr. Vaughn, and please send your questions, and we will try to get to all of your questions.
Thank you very much, Anne. It's such an honor to be here. And I was asked to put together a very brief PowerPoint presentation, which I'm hoping is going to serve to help guide discussion. Can I confirm that you guys can see this? Or that the screen is effectively being shared?
I don't see that yet, Jennifer.
No. All right, share screen. Here we go. Let's try again.
It's there now. Thank you.
Wonderful, wonderful. Okay, thank you. All right, so thanks again. And as Anne said, my name is Jennifer Vaughn, and I am a faculty member at The Ohio State University in Columbus, Ohio, and work within the James Comprehensive Cancer Center. And my specialty is in the diagnosis and treatment of patients with myeloproliferative neoplasms. Actually came to Ohio State in 2019 after having served as a community oncologist for about 5 years, which was an amazing experience because I got to take care of patients from all different types of cancer backgrounds or with all different types of cancer diagnoses. But then after coming to Ohio State, was very excited to focus on the care of patients with MPNs, and that's what I've been doing since that time. I shared that background with you, though, because it was really that time in community practice where I became very impassioned about understanding how to determine value in the treatment of any cancer, but in particularly now, how do we determine value in the MPN treatment journey? And I just want to share with you all that I do not consider myself the expert in this. I consider you as patients the experts on this topic. And so I'm hoping and excited to actually really generate a discussion today where I get your feedback on the topic and really get ideas from you on how we can take these matters better into account in the clinical setting. So very briefly, I just wanted to say I do have some disclosures. None of these disclosures should have any relevance to the discussion we're having today, but wanted to make sure that they were out there. And like I said, my goals for today are to generate a discussion and to hear from you most importantly. I'm going to start by just highlighting some financial trends that are impacting the healthcare system and are basically guiding the thought process on how we're going to be taking care of patients in the oncologic setting in the future. And then discuss how these same factors may be impacting our MPN patients or you as an MPN patient. And then I truly believe, I'm becoming more and more convinced that it is so important to encourage patients to start thinking about what value means to them in the course of their care. And so I'm going to provide a framework for that. But then again, what's most important is to hear your thoughts on that framework and on this topic to help advise me as a physician on how I can bring these topics to the forefront of MPN care in general, but and most importantly for my patients. So just briefly wanted to start with some good news, which is that overall in the oncologic world, we are making progress. This is a graph that shows death rates from all cancers, not just hematologic cancers, but also solid tumors. And you can see that over time, we are experiencing fewer and fewer, our death rates are actually declining. Unfortunately, I think you'll notice the United States here is not keeping up with the rest of the world for reasons we might touch on a little bit later on in this presentation. And as we're seeing these reduced numbers of death, we're also seeing a very large rise in the number of cancer survivors. So what does cancer survivor mean? Someone who is living after a cancer diagnosis, and that can be for any amount of time. But it's important for you to know it doesn't just include people who've been cured of their cancer. It's people who are living with a cancer and being effectively treated, often for decades at a time. So more and more with effective therapies, cancer in general is becoming a chronic disease. We have developed some cures and some increase in the number of curative therapies, but overall, our real achievement is that we're creating effective therapies that are allowing patients to live longer with treatment. And patients with MPNs have been the example of this type of patient for many years because we're happy that patients live for a really long time, but do require many, many years of therapy. But with progress, there does come some cost. So one of the concerns about progress is that we are experiencing an exponential rise in the cost of cancer treatment, whether that be the cost of cancer therapeutics or drugs, or the overall medical care or cost of medical care of cancer patients. This was a figure that I actually took from the website of the Fred Hutchinson Cancer Research Center in Seattle. But you can see that this percentage of increase in cost is well outpacing even the US gross domestic product, which is highly concerning from a governmental and healthcare system level. To bring this a little bit closer to home, this was an article that has been recently published in 2022 in The Oncologist by Rhonda Cofer and colleagues that actually looked at the cost of care for patients in the 6 months prior to a diagnosis of myelofibrosis and the 6 months after their diagnosis. So in the blue bar, you will see the average cost of patient that was being spent by an insurance company or a Medicare Advantage insurance plan 6 months prior to getting diagnosed with myelofibrosis. And then you'll see across the board, those costs significantly increase in the 6 months after the time of that patient's diagnosis. And when you look at the total cost, which include total medical cost and pharmaceutical or drug cost, that number over doubles in that short time frame. So all of these cost experiences have really come to the forefront of attention at the governmental and payer level, not surprisingly, and has really led to the development of a concept called value-based care. Many of you may have heard of this concept or this terminology, in the news or even at your clinic as your providers are beginning to think how they're going to be adjusting their practice. The Centers for Medicaid and Medicare Services, or CMS, defines value-based care as healthcare that is designed to focus on the quality of care, provider performance, and in bold and underline the patient experience. And I added that touch because I want you to know the important role that patients and their input is going to play as we develop these care models. At a more granular level, we have this is sort of born out in the idea of something called alternative payment models. So again, these are things that are these are payment strategies that are going to reward providers and healthcare systems for prioritizing quality and value of care over the number of services they provide, which is how traditionally healthcare systems have been reimbursed. So how is that going to look for a MPN patient, for example? So someone who is diagnosed with myelofibrosis will, in theory, be presented with a package of care, or the healthcare system will be reimbursed based on a package of care that they are provided. And that package of care is going to be designed based on the experiences of patients with myelofibrosis in the past. Theoretically, this is a very positive thing. This will incorporate a holistic approach to sort of more focus on symptom management, more focus on reducing costs of inpatient stays, emergency room visits, et cetera. But also needs to take into account, cost of the treatments that are being offered to the patients themselves. Another important trend that is affecting sort of these cancer costs, and one that I really wanted to discuss today, is that more and more the treatment of any cancer is being moved from the infusion center where patients get IV chemotherapy or different treatments to the outpatient setting where patients are being provided drugs that are developed as oral agents or injections or things that they can administer to themselves at home. And, when you ask patients, there have been studies that looked at this, and by and large, patients are very positive about this idea. I mean, being able to give yourself your own treatment at home reduces your need to go into the infusion center, your need to miss work, way more convenient. And theoretically, it reduced costs, right? Because you're not actually having to pay for all this equipment. You don't have to pay for the specialized healthcare staff. However, one important cost that has come up is what it means to the patient in terms of out-of-pocket costs. As many of you have probably experienced, oral drugs and self-administered drugs are covered under, for most patients, they're covered by prescription plans, which unfortunately have designated copay percentages, right? And unfortunately, again, these drugs can be extremely expensive. And so this is a figure that I took from an article in JAMA Oncology about all cancer oral drugs. But I wanted to highlight that, these dark brown bars basically show the increase in Medicare spending over time in billions of dollars, as you see here on this dark x-axis, or sorry, y-axis. And then these tan bars here actually reflect the amount of the total amount that is being spent out of pocket by patients. So certainly, pales in comparison to the amount Medicare is spending. But when you think about that, these numbers reflect billions of dollars that are coming out of patient pockets, quite concerning. And so this type of awareness is leading us to also think about this concept of financial toxicity and how we could be imposing this on our patients. The definition of financial toxicity that I'm presenting here from this source defines it as the detrimental effects of the excess financial strain caused by the diagnosis of cancer on the well-being of patients, their families, and society. And we tend to think a lot about financial toxicity in the sense of like, how much is the patient paying out of pocket? How is this affecting them, their overall financial well-being? But I will tell you more and more as I practice, even patients who have access to a lot of resources still experience a degree of financial toxicity because of the subjective stress that it imposes. Most of these copays are significant. And even patients who are middle to upper class have to spend a great deal of their time applying for foundation grants, assistance to be able to cover their copays, or if they don't qualify for that assistance, they have to make choices. They have to decide whether they're going to pay for their drug on a certain month or actually take the fancy vacation they were hoping that they worked very hard to get to pay for and take with their family. So that subjective type of stress is also part of the financial toxicity and should not be ignored. Certainly, patients who are at lower income levels can suffer severe financial detriments. There have been studies to show that cancer patients file some of the highest rates of personal bankruptcy, incur some of the highest rates of debt in order to pay for all of their treatment, not just their oral drugs. And unfortunately, this leads to worse outcomes. So it leads to decreased well-being. The stress in and of itself can contribute to decreased quality of life and increased mortality. And what's really concerning is that it's been shown to be a direct effector of poor adherence among patients to their cancer regimen. So they make trade-offs. They might only take one of their pills in that day as opposed to the two they're supposed to take in order to extend the life of their drug, or they just don't fill it and don't take it because they can't afford it. So then, this poses a question. What are we as a healthcare system, as advocates, as patients, what can we do about this issue and how do we address it? I wanted to first show you something that is being encouraged by the National Comprehensive Cancer Network in terms of encouraging providers to think about the overall value of the treatments that they are recommending to their patients. I hope many of you have heard of the National Comprehensive Cancer Network. They publish every year something called the NCCN guidelines, which is used by many oncologists and hematologists around the country as a reference point to sort of keep abreast of the latest and greatest and most effective treatments to offer patients. And a few years ago, because of all of these financial impacts that were being noticed at the larger level and at the patient level, they began incorporating these things called NCCN evidence blocks into the guidelines. And as you can see, so this is the example of how these evidence blocks work. So it basically ranks all treatments that are recommended in their guidelines on 5 different parameters. One being the efficacy of that treatment, obviously important, the safety of the regimen or the treatment. So ranking like the difficulties with toxicity that were experienced by patients in trials, the quality of the evidence behind that drug's approval. So, how rigorous was the clinical trial? How good was the science behind it? And then the consistency of that evidence. How many trials showed similar outcomes? And then finally, and most pertinent to this discussion, the affordability of that regimen. So with 1 being very expensive, so ranking lower on the affordability scale, versus 5 being very inexpensive. And so all of these are ranked 1 to 5, with 5 being the optimal score. And then these blocks are basically filled in based on that scoring system. And that perfect drug, the highly efficacious, highly safe, highly affordable drug would be all blue squares here. But I can tell you, I don't think that there's one drug out there on these guidelines that meets all of these perfect criteria. And so it's really a way to sort of weigh the risks, the quality, the value overall of the treatment that you're recommending. The reason I wanted to bring this to the patient's attention today is because if your provider actually uses the NCCN guidelines or subscribes to these NCCN guidelines, they have these quality blocks available. And you should feel very, very justified in asking your provider if they have reviewed these evidence blocks and to go over them with you in terms of, these different rankings so that you and that provider together can weigh the risks and the benefits and, the cost of those drugs in terms of their value and participate in shared decision making. The last slide I promised that I wanted to share was actually in thinking about how I could, as a provider and an MPN, a person who sees MPNs, could encourage you to think about how you want to define value in your MPN treatment journey. As you all know, this can be quite complex because many of the clinical trials that led to the approval of drugs in MPNs had alternative outcomes, and actually commend the trials that were done in many of the treatments for MPNs on really focusing on patient-reported outcomes as being an important outcome that led to their approval. So, when you're thinking about if your provider is recommending a treatment, or if you're going to be meeting to discuss a treatment, I really want everyone to think about what are the different outcomes that are important to you. In MPN specifically, that could be a decrease in spleen size. It could be improvement of your symptoms. It could be improvement in your anemia, because one, anemia makes you feel terrible, but also anemia leads to inconvenience. You end up having to spend a lot of time getting transfusions in the clinic. Obviously, in the treatment of MPNs, we want to reduce risk, whether it be a thrombotic risk or progression to something more severe in the future. And then think about, how important is a survival benefit? We have very few drugs that provide cure. In fact, I don't think we have any drugs in MPN other than transplant that provide a cure. But, that is something to consider. And I don't want you to discount convenience. Because that is something that, many patients do value. It's more important for them to be able to give their treatments to themselves at home as opposed to having to come into the clinic. And they're willing to accept a little additional cost in order to have that convenience. And then, take all those outcomes into account. There are probably many that I'm not thinking about here, and would love to hear your thoughts on that. But also compare that to the cost to you. So whether that be financial costs, given your copay, and whether that's going to have an impact on your lifestyle or quality of life, or if it will impact your quality of life because of the toxicities that are associated with the treatment. Or, what is the psychological impact of that treatment for you? One of the big ones is watchful waiting, right? If you're asymptomatic, but how do you feel about that? Is that causing you a significant degree of stress, feeling like you're not actually actively treating your illness? So, and again, probably lots of other different costs that you've experienced that I would love to hear about. But, this is really to provide you first and foremost with the encouragement to discuss value with your provider when you're thinking about your therapies and what you want out of your treatment experience. And then secondly, to really think about weighing what is most meaningful to you, because hopefully you will be receiving management, monitoring, treatment for many, many years. And so it's important to think about this early on and to reevaluate as your life changes and as your priorities change going forward. So that is all I had. I again really apologize for being so formally presenting a formal presentation, but hope this will provide a framework for a robust discussion. And again, I'm happy to answer any questions too that you all may have on or off this topic. So
I cannot thank you enough. This was so informative, and as a advocacy organization and educational organization, it has struck a real firm chord with us, especially this year, because we were introduced to PDABs. Are you familiar with those? They're prescription drug advisory boards that are sprouting up across the country. Typically, the governor has a say and the governor of each state has a say in what's going to happen in that PDAB, and then the advisory board is brought together. And we are working hard in trying to figure out. Colorado has the most robust group and is pretty much doing the work right now. But there's a concern about rare diseases and about rare disease drugs. And we want to make sure that the MPN community has a voice at these PDAB board meetings, and they're open to the public. And I'm hoping to meet with people in Michigan, the governor here, and some other folks to have that discussion, because we're very concerned about it. And so, especially with, the rare disease and the cost of a rare disease drug, as is pretty significant. But I have actually several questions here for you. And I can't thank you enough. Again, I'm just going to tell you that this is so important. So we have patients that are actually saving their injectable medication. They inject one day and put that vial back in the refrigerator and or share it with other MPN patients because of the cost of some of the injectables. And what would you share with a patient that they should be doing? We tell them we can try to get help for them to pay for the drug, but it's changing. It has changed over the last several years in terms of how much, of the drug is in the injectable. When we were first able to get Pegasus approved for MPN patients, and I was very much a part of that, by the way, they said, well, we'll give you the vials, but we can't give you a certain amount in each vial. So we know patients that are still saving that drug. So can you share your insights on that?
I can. I mean, I just highlights the number one thing I want to get out from this discussion today is to please encourage or to please ask you to share these types of things with your providers. So it is so important for me to be aware that this is something that that a patient is having to do in order to be able to cover their medication. And it goes back to exactly what I talked about as to why we're having inferior outcomes in the treatments, in our survival outcomes, things like that, because patients, this puts you at risk of not taking the right dose of the medication, not not getting it as prescribed and not getting the full efficacy that you deserve from actually receiving the treatment. There are,
Isn't
I'm
it,
sorry.
or couldn't it be contaminating, once
It
you?
absolutely can be
Yeah.
contaminated. Certainly if you're sharing, you do not want to share any kind of injection with another patient. That is so dangerous. Absolutely true. I'm glad you said that. And so puts you at risk, puts your, the other person at risk. And there are avenues, to try to get assistance. Most oncology practices, whether it be a community practice or a big academic center or a big hospital-based center, have a team of people now that are hired in order to be able to help you find the right types of coverage. So find grants from the drug company, find sort of advocacy or charitable groups that are actually willing to help provide additional financial assistance, and really to be able to work through the best way with your insurance. It can be impossible to navigate how to get things paid for with insurance. So they are really experts. I know nothing about how to do that. So I fully rely on this team of experts to be able to get the most payment reimbursement.
We have patients that are parents of children that have had to really go to bat with the providers to get payment for treatment and for just general visits to the physician and so on. And so Dr. Vaughn, this question is about, and I don't know if you have the answer to this, but it has to do with Medicare and and we actually had to go to bat with Medicare on a couple of occasions when it came to stem cell transplants. And they were unwilling to pay for stem cell transplants in some cases. And we were able to change that a little bit. And some of our MF patients were able to get funding. And so the question is, do you, as an MPN physician, ever have to really sit down with the patient and say to yourself, I'm not going to prescribe this because I know that my patient cannot afford this? Oh, you froze in one. You're there you
I'm
go.
so sorry. My Zoom just kicked me out. I don't know what happened. I apologize for that. I'm back. So you were asking about Medicare.
Yes.
Sorry, that was the last thing I heard.
Did you hear the question? Did you hear the question?
I just heard you start talking about Medicare, and you had to go to bat for Medicare.
Yes, and then the next part of that question was, do you as an MPN physician ever sit with a patient and know that their financial situation is not going to allow them to pay for a certain drug, and maybe that drug would be best for them? Do you ever have to say, we're going to keep you on HU or, do something? I mean, how do you deal with that?
So I talked about being in community practice in the past. And so the person who actually inspired my interest in this topic was a woman who actually had chronic lymphocytic leukemia who came to see me. And it was right after there had been a lot of studies to show that these new oral medications were going to be the most efficacious for patients with CLL when compared to the IV chemotherapies we had traditionally been giving, right? And so I told her about this. I was really excited that I could provide her this great treatment. I wrote the prescription. She came back to see me, and I remember her sitting there looking at me and saying, yeah, there is no way I'm going to pay for this drug. I'll just take the other chemotherapy. I need you to figure out something that's cheaper. So yes, this has happened several times to me, and it is heartbreaking to experience that. So I will tell you that, again, the most important thing and the thing that I so appreciate about that patient is that she was blatantly honest about it. She said, this is just, I'm not going to make the trade-offs to pay for this drug. And so first of all, it allowed me to really go back to our financial advisors to have them to take a deeper dive, to look for options. And I will tell you, in the end, they still were not able to provide an option for her that she found acceptable. And so we went with the IV chemotherapy, which thankfully very good in that area. And so, but in a person who has a more limited prognosis, that can be very, very dangerous, number one. And then, in MPNs too, we have so many amazing therapies that are, all this great research is coming out, so many new breakthroughs, and to not be able to offer someone the latest and greatest is really disappointing, and I find unacceptable.
Many of the companies that support us and support our work, they're partners, and they do have a charitable arm that helps. Many of them will say to me, please, if you know a patient that cannot get this drug, let us know. We will make sure they get it. And so that does that makes us feel better. But we know that there are lots of hoops they have to go through sometimes. And then we also partnered with the PAN Foundation in Washington, D.C., and they will support patient treatment costs up to a certain amount every year, depending on the criteria that the patient meets with their program. But it's very, very effective, and it's been very useful for MPN patients. Sometimes they can't do it. They have to wait till funding the next year. But there are avenues. So I always encourage patients and even physicians, send me a note and say, listen, I have this patient. I'd love to have this individual on Jakafi or whatever it is. And we will see what we can do, to help. Here are a couple more questions. How do you decide the line of treatment or the perfect time for a stem cell transplant?
So that is a great question. So the line of treatment, so going back to this whole concept of these NCCN guidelines, right? So these are based on sort of the clinical trials that there's a team of experts that gets together every year, reviews all the clinical trials that have been done, and all the approvals by the FDA for different diseases. And then they decide, what is recommended in first line, second line, et cetera. But that is sort of how we as providers think about, what we should be offering to our patients. Sometimes that can get complex though, because, we have a drug that we think would be particularly beneficial to a specific patient for whatever reason. And that drug is only gained approval in second line for this particular disease. And so the problem, the negative side of the NCCN guidelines or published guidelines like that is they're also highly relied upon by payers, right? So that can be a benefit if they're trying to argue against paying for something that you want to give your patient, but you can pull up the guidelines and say, no, look right here, it says that this is approved in, first line, second line, et cetera. But it can be a negative impact if those drugs, if they don't make the guidelines in terms of the recommendation level. And so the quality of evidence based on, so I would say the answer to the actual question is twofold. One is we do use guidelines. We do use the clinical trial evidence in terms of what patient settings those drugs have been tested in, from an ethical standpoint, from an efficacy standpoint. But then also you do look at the individual patient. People, I train a lot of fellows and they're always very reliant on going and looking at the guidelines, but the art of oncology and all medicine in general is not just using those guidelines, but looking at the patient in front of you and how do you apply those recommendations to the person who's sitting across, what is their disease process? How's their disease behaving? Is it aggressive? Is it indolent? Or does this person have a lot of other medical conditions that are going to prohibit you from giving some of these drugs because of toxicities, et cetera? So that's the first part, how you decide what line of drugs. The second one is transplant. So I will tell you, I was just in a meeting this weekend with a lot of people who take care of MPN patients, and that topic continues to be very controversial. There are many things. So stem cell transplants in general are not benign, as you all probably know. And if some of you have had them, you know what a difficult process it is to go through. If you have friends or know people who've been through it, it comes with a lot of risk. There's an infectious risk, there's the risk of graft versus host disease, and there's a risk of death just from the treatment in itself, right? So it is the only treatment that provides a cure that we have in MPNs right now. At least that we're aware of. And so what we do, the way I decide this is I weigh the risk of the person's disease against the risk of having an unacceptable toxicity from the transplant itself. And so that is why most patients are being recommended, if they are high risk, the myelofibrosis patients with high risk sort of genetics associated or certain clinical features that make us fear that that disease is going to be at risk of progressing quickly, tend to be recommended for transplant. But then we have to decide, how fit is that person to undergo a transplant? So, do they have a lot of medical conditions that are going to make them, make it very difficult for them to make it through the process? There's a big question about age out there. Certain transplant centers will not transplant anyone over a certain age, like 70, 75, et cetera. But what we're learning is I personally have many patients. I'm not saying I would recommend they have a transplant, but I have some very fit patients in their 90s that I take care of.
I know some of them.
Yeah, and some very unfit patients in their 50s and 60s,
Yeah.
right? And so, again, looking at the patient sitting in front of you, and there's, who they are and what their associated risk may be, and what kind of survival benefit they might get out of the transplant. But the big controversy is, when do we go for it, right? When's the moment? So especially with the advent of JAK inhibitors, what we're saying, this was part of the discussion. A lot of people come in, they get a great clinical benefit from JAK inhibitors. And, they can go from even years on a JAK inhibitor and do really well, feel good, patient's happy. But if you wait too long, now they've developed other medical conditions. They've developed toxicities from the JAK inhibitor, they've gotten older and they're just less fit than they were. And so there is this elusive magic that we're still trying to figure out, as to finding the perfect time when it's time to pull the trigger and move forward with the transplant itself. And it's very complicated decision, requires multidisciplinary discussions. And certainly, you should question, as you're talking to your providers about this, ask them, like, what is going into your decision making about that? Be transparent with me. And if stem cell transplant is something you really are interested in pursuing with curative intent, what are things that they can recommend to you to make you the most fit to be able to go through that process with success?
The difficulty is the FDA, what
Oh,
will
yeah.
the FDA accept? And the second thing is, we talk to very fit younger patients who say, I would like to have a transplant, and they can't.
Right.
They do not meet the scoring, that has been set thus far. Moving on. Have the evidence blocks by the NCCN gone into effect now for MPNs? And what about other cancer diagnoses?
They are absolutely in effect. So, I did not want to bring up like the specific blocks for the drugs in MPNs, but if you are meeting with your provider, they can pull those up for you right now at your next visit, and you guys can look at them, factor by factor in terms of overall sort of how an external committee with expertise in this area is viewing the value of that recommended therapy.
That's great. So in your practice with, over 150 MPN patients, are you seeing trends now? I mean, we already know that patients are living longer, that their quality of life can be much, much better with the new treatments out there. And I remember, again, 21 years ago, and most of the patients were getting phlebotomy, HU, and we're not living that long. And so, I would just get to know someone, and months later they would not be there. So it was a really interesting, it's been a very fascinating time for me personally. So are you seeing some trends, not only in longevity and quality of life, but in other ways with, whether it's positive or negative? Are you seeing more younger people, as we are? We're starting to see many, many young people diagnosed with a lot of ET, in females, young females. And what has been your observation?
Yes, I am absolutely. So, being an MPN focused clinic, and one of the focuses of our clinic is diagnostics. So I actually sit in the section of, believe it or not, benign hematology, and I definitely do not include MPNs as a benign disease. But the reason this is advantageous is because many referrals come in from primary care, et cetera, for elevated platelet counts, elevated red blood cells, these moments that you've all had where your number turns red on your labs and alerts you that something's going on. Sometimes that can be nothing. It can be something that can just be managed, with a little iron supplementation, something like that. But what I think has been very innovative and effective about our clinic design is that as we see these patients, we are very aggressive. I think maybe I consider us pretty aggressive at trying to screen for any underlying genetic mutation that could be the driver mutation that's leading to these. If we have an obvious cause, certainly we don't want to do that until we can eliminate those other obvious causes. But we are very astute at ordering testing for, the primary driver mutations very early on. And I think as a result of that, we have accumulated many young patients in our clinic. And it's been kind of eye-opening because a young woman, for example, is at high risk of developing iron deficiency because they have periods regularly, right? And so one of the side effects of iron deficiency is you develop elevated platelets. But what's nice about having those women show up early to our clinic is, yes, we can treat that iron deficiency and we can watch them very closely. And if there's no resolution, we get them screened. So I think this increased awareness is actually picking up a lot more patients at an earlier age and earlier stage of their disease.
Mm-hmm, mm-hmm. And, we talked a little bit before we went live about women, and I'll just stay on that subject for a moment as we are approaching our 10th annual Women in MPN conference in September. And, we just received a message, and we've had this discussion before in other webinars and in-person events, particularly that men and women do have different issues with their MPN. And I remember, her name escapes me. Oh, Alison Moliterno from Johns Hopkins wrote a paper years ago about the gender differences and how men tend to suffer at the upper half of their bodies and women tend to suffer from the lower part of their bodies. And this woman had sent a message earlier this week about menopause and how her oncologist and hematologist said, I won't treat you if you continue hormone treatment. And her life is just tumbled since then. And so, do you have any advice for some of the women listening today that are going through this, and how do you, because we know the dangers of thrombotic events and blood clots and so on with some of our MPN patients. And so how do you counteract some of this and work with a female patient on this?
Right. It can be challenging in many ways. So in order to address sort of the idea of hormone supplementation first, I have to say, as a woman who is aging, getting into the middle-aged portion of her life, I have a high interest, and I've been encouraged to see that some of that data that led to the I guess damnification, is that a word, of hormone supplementation for women in the postmenopausal era is being sort of reevaluated. I mean, it was good data to show that there are increased risk, and I don't want to discount that. And that's for people without MPNs to taking hormone supplementation. But I think a lot of people, there have been a lot of advocates in women in, of this age group to say, let's take a look at that and let's really have us all participate in shared decision making. It's good to be aware of the risk. It's also good to think about how we could mitigate risks that might be associated with taking those hormones. And then at the end of the day, it's my body. I am the one who has to decide whether I'm willing to accept that risk. Again, what's valuable to me? as a patient and in my treatment. So that takes a whole step up when you talk about someone who may have a JAK2 mutation or a mutation that puts them at higher risk of developing thrombosis. So the problem with that data about hormone supplementation is that average women without a diagnosis were at higher risk of strokes, heart attacks, thrombotic events. And then you add an extra risk factor like having an MPN. It is concerning, and I certainly makes me nervous to think about giving one of my patients a hormone supplement. But again, I think it's important for providers to recognize that patients own their experience, they own their journey, and that it isn't important to have a discussion about what risks they are willing to accept and to own that. I have patients who refuse to take Hydrea, even though I think they need it so badly. And it's ultimately it's their decision, you know, but I'm here to support them through it and to just continue to educate them. And so the other thing, I think there really is a need for research in this population to try to figure out if there are ways to mitigate risk. Like, are there certain forms of supplementation that carry less risk? Topical, like patches, for example, may carry less risk than sort of oral supplementation. Are there certain symptoms that we can treat of menopause without giving systemic estrogen therapies that might mitigate risk? All of this comes into play as part of this.
Yeah.
The other interesting part about menopause and MPNs is assessing symptoms, right? So night sweats, especially in my patients with ET and PV, I'm always, you know, screening them again for any signs they could be progressing to myelofibrosis or a more serious form of their illness. And night sweats is one of those things that can kind of trigger there might be some form of progression. But is that, you know, a different biologic process that's going on with the patient versus disease? So
Ellen Ritchie was with us last week, and she was the one that did the study on cardiac health in women with MPNs. And, you know, there's so many symptoms of MPNs that are so much like menopause symptoms, you know, the foggy brain and the night sweats and, you know, a number of other things. But yeah, I think there absolutely does need to be more research just in general for women's health. And but also more specifically for women with the blood cancer MPNs that are going through the different things that women experience in life. And so in wrapping up, and I can't thank you enough, what would you impart to our viewers today and subsequently, because many watched this afterwards, that, you know, some of the good things that are happening in the MPN world, we know some of them, but what would you share from Ohio State? Like, what's happening in your world?
Oh my goodness. It's funny. I was sitting down with a friend of mine the other day who's a community oncologist, and she just made a comment that she's seeing people coming out of fellowship with a real interest in caring for patients with MPNs. And she's like, what's going on? Like, why are all these fellows now suddenly interested? It is a really exciting time in MPNs. I think we've always kind of lagged behind in terms of, you know, developing new treatments or having a focus in the past, because, you know, there are patients with other myeloid malignancies that can be more severe or more aggressive in the short term. And thanks to organizations like yours and advocacy groups and patients really speaking up, there's really been a turn to try to figure out how to develop targeted therapies that are effective and potent, but carry less toxicities for patients. Knowing that, you know, with the goal of knowing that our patients are going to live for a really long time and we want them to have the best, longest lives, but also maybe more importantly for some patients, the best quality of life for the longest time possible. And because of all, I think, you know, again, you have experts come and talk to you all the time about all the new drugs that are coming out and all the new exciting research. I think also the idea that we're starting to see some trends in some of the studies that we can actually reduce the allele burden of some of the driver mutations. And I keep telling my patients how exciting that is, although we don't have all the data yet to say it's really going to be of benefit, but I'm really excited because in my mind, in my heart of hearts, I think it should have a benefit in terms of reducing progression overall and extending lifespan for patients. So, and the fact that we're seeing signs that we can do that has now led to more research in terms of like, what can we do that's actually going to prevent progression in the future, not just mitigate that immediate risk, but prevent people from developing more serious disease.
Fantastic. And that's what, I mean, we're just so excited about the new drugs that are out, the drugs in the pipeline, but also even the clinical trials and stem cell transplants are fantastic. And the other research that is very pertinent and important to MPN patients is excellent. I thank you. You took a wonderful hour out of your day to do this, and we appreciate it. And we're going to do some industry partner updates now. We just hear from a few of our partners, and they will give some updates. You're welcome to stay, or if you need to get back to work, we understand. We will call on you again for sure. This was so interesting, and I'm so glad you joined us today. Thank you.
Thank you so much for the opportunity. I really appreciate everyone. So.
Thank you. So we'll move on, and our first update is going to come from Kristen Griffiths, who is with Insight, and she's the Associate Director of Communications and Patient Advocacy. Many of you have met her before or have seen her before. Hi, Kristen.
Hi, thanks for having me back.
Yes, and this is pertinent to Insight in this ways. Insight Cares. We always tell people there are ways to help get your meds if you need them.
Yes, I will definitely touch upon that. But first, I just want to say hello to everybody. Thank you so much for having me here today to represent Insight. It was so wonderful to hear from Dr. Vaughn. Wow, she's really fantastic. And thank you so much, Anne and the team and MPN Advocacy and Education International for giving me a few moments. So for those of you who don't know about Insight, we are a Wilmington, Delaware-based biopharmaceutical company, and we're committed to making a difference in the lives of patients through scientific discovery. Rigorous science is at the core of everything we do, from discovering, developing, and delivering novel medicines that meet the serious medical needs in oncology and other diseases as well. So patient access is one of the most important things we want to talk about today. And one of our commitments is to ensure that we help eligible and appropriate patients have access to the medicines that they need. And so for this reason, we developed a patient support program called Insight Cares to help appropriate patients and healthcare providers access their prescribed medication. For eligible patients, Insight Cares offers prescription insurance verification and prior authorization support, free drug and copay assistance for those who qualify under the program's terms and conditions, as well as ongoing education and support from a representative. Patients who have concerns about their access to their prescribed medicines should contact Insight Cares for assistance. And for information about patient access, you can find it on insightcares.com. So that is INCYTE cares.com. And we highly suggest that any eligible patients enroll in Insight Cares, even if you don't think you'll need it at first initially, because circumstances can always change. And if your eligible patient are enrolled, we can help you receive your access that much more quickly. Just one other note, we are currently enrolling eligible patients in clinical trials for MPN. So if you're interested, please contact your healthcare provider. And detailed information about Insight's clinical trials can be found at insightclinicaltrials.com. And since we have a bunch of patients on the line, I'd love to talk a little bit about how we support the community. We really strive to enhance support through the patient community to integrate an authentic patient voice throughout our initiatives. So the partnerships we have with MPN Advocacy and Education International have been really key in helping us understand the unmet patient need, as well as caregiver needs, including raising disease awareness and providing educational information to the community. We host a website called voicesofmpn.com, where we provide access to MPN information such as patient stories, MPN community events, Facebook Lives, patient meetings, podcasts, and also symptom tracker tools. We also have a program called MPN Heroes, where we publicly recognize individuals who have excelled in caring for patients, or patients with MPN who have advanced, and then also individuals who have advanced the science in MPNs to increase awareness and support the MPN community. So those nomination windows are open now. And lastly, we at Insight believe that industry and patient groups can find a common ground to develop collaborative partnerships resulting in meaningful activities. And programs like this allow Insight to use our resources to help improve the lives of individuals impacted by the diseases in which we work. So thank you so much again. It was great to hear everybody's questions, and we'll see you soon.
Thanks, Kristen. That was great. Great update. Talk to you soon.
Thank you.
And next is AbbVie and Brian Murray, who's the Associate Scientific Director. Hi, Brian. Good to see you.
Good to see you, Anne. It's been a little while.
Yeah.
All right. Well, as Anne mentioned, I'm with AbbVie. Hello, everyone. Thanks for having me here. So AbbVie has a history of developing multiple drugs for blood cancers, both leukemias and lymphomas. But today I'm here to talk to you about what AbbVie is developing for myelofibrosis, which is a drug called navitoclax. Now, it's important to note that navitoclax is not FDA approved. It's investigational. Safety and efficacy are ongoing. I'm here to talk to you about an ongoing and enrolling clinical trial that's in the phase 3 setting. But before we do that, I want to talk to you about what navitoclax is and how it works. So navitoclax, as I mentioned, is a small molecule drug that binds to a protein called BCL-XL. BCL-XL is what we call pro-survival protein. And to simplify things, what cells can do, including myelofibrosis cells, is they can hijack this pathway and overproduce BCL-XL to keep themselves alive. And we found that when we combined a JAK inhibitor like Jakafi ruxolitinib with navitoclax in a laboratory setting, we found that both of those drugs together tended to kill more cells than either drug alone in the setting of myelofibrosis and MPNs. And so the company set out to investigate this in the clinical setting, looking at both these drugs in combination, both in JAK-naive patients, so patients who had not received Jakafi, and those who had received but maybe were progressing or doing worse on the drug. And we found promising efficacy signals in both settings. So the company started 2 phase 3 studies a number of years ago, one of those in the JAK-naive setting, combining navitoclax and ruxolitinib, and that trial, which is Transform-1, is fully enrolled and now no longer looking for patients. But Transform-2, which is the trial I'm here to talk to you about today, is enrolling patients and is looking, we're still looking for patients on the study. So this trial is for patients with myelofibrosis who were on ruxolitinib, Jakafi, but are now progressing. So their spleen is growing, their blood counts are worsening, and they need other options. And so what we're looking at in this trial is 2 different treatment arms, one navitoclax and ruxolitinib in combination. And then the second arm is called best available therapy. So your physician will have a choice of therapies, such as continuing ruxolitinib, perhaps at a higher dose if it's possible, or other treatment options as well. And so we're looking for patients across the country. We have about 30 sites in the United States total. So if you're interested in this trial, I encourage you to speak to your physician. You can also visit www.myelofibrosisresearch.com for more information on the trial, the eligibility, and there's even an eligibility questionnaire to see if you might be eligible, as well as a Google map showing the locations of the currently active trial sites. So once again, that's myelofibrosisresearch, all one word.com for more information. I think that's my time. So thanks again to Anne and MPN A&E for having me here. Always a pleasure. Thank you so much.
I'm having a little bit of technical difficulty over here. Thank you so much, Brian. I appreciate it. And now we'll move on to GSK and Nicole Widener, who's the Director of Patient Advocacy and Engagement. Hi, Nicole. Good to see you.
Hi, good to see you guys.
I have airport.
Okay. I'm in an airport, if you cannot tell, in a lounge, so forgive me if you hear any
No, that's okay.
50s doo-wop in the background. It will just be an added experience for everyone. So good afternoon, and thank you so much for allowing me the opportunity to speak with you today. As Anne mentioned, I'm Nicole Widener, Director of Patient Advocacy for GSK. I'm pleased to be here, and I just want to tell you a little bit about GSK. GSK is a global biopharma company with a purpose to unite science, technology, and talent to get ahead of disease together. GSK is focused on maximizing patient survival through transformational medicines. Our focus right now includes immuno-oncology, tumor cell targeting therapies, and synthetic lethality. Our goal through all of this is really to achieve a sustainable flow of new treatments based on a diversified portfolio of investigational medicines, utilizing modalities such as small molecules, antibodies, antibody drug conjugates, either alone or in combination. So Ojjaara, or sometimes it's called momelotinib, is approved for the treatment of intermediate or high-risk myelofibrosis, a drug that GSK makes, and it includes primary myelofibrosis or secondary myelofibrosis in adults with anemia. Ojjaara is a once-a-day oral JAK1, JAK2, and activin A receptor type 1, ACVR1, as some of you may hear that, inhibitor. And it is approved for both newly diagnosed and previously treated myelofibrosis patients with anemia. So Ojjaara has been studied with regard to key manifestations of the disease, namely anemia, constitutional symptoms, and splenomegaly, or an enlarged spleen. So each person, as you all know, experiences myelofibrosis differently, which can make navigating symptoms daunting. But despite this increased focus on resources in the past decade, there is a need for a clear roadmap to help those impacted by myelofibrosis and their loved ones chart really their next steps to better navigate the disease overall. So Mapping Myelofibrosis is a website created by GSK. It's an initiative really designed to create a increased awareness of this complex blood cancer, and which can obviously be difficult to diagnose. So whether you or someone you know faces or has been living with this type of disease for several years or is experiencing symptoms without a diagnosis, Mapping Myelofibrosis, it connects the community and with educational tools, resources, and stories, patient stories specifically, to help navigate all these aspects of the disease and help encourage conversations with your healthcare provider. The Mapping Myelofibrosis website can be accessed at mappingmf.com. Again, that's mappingmf.com. I also want to just give a quick note about our patient access resources for the patient community, which I know is so important and was discussed today. So thank you, Anne, for bringing that up. And so to support patient access, GSK for You, which the website for that is www.gskfor.YOU. So GSK for You, all one word, is a program committed to assisting eligible patients access to all of our medications. We offer programs for patients who meet income and other eligibility requirements. We can go to that website for more information as well. So to close, I'd just like to add that we are so grateful to Anne and the MPN Advocacy Education International, as the entire myelofibrosis advocacy community, for all the work you're doing, Anne, and your team, to raise awareness, educate patients with your organization. So I thank you for this opportunity to tell you about what we're doing here at GSK Oncology, and thank you so much for your time.
Thank you very much, and safe travels wherever you're going. But
Thank you.
again, just to reiterate to those with us and those that will be watching later, all of these companies that have drugs on the market currently have programs that can help you get your treatment if you need it. And so finally, we'll hear from Leslie Ferber, who is with Sobi. She's the Associate Director of Patient Advocacy. Hi, Leslie.
Hi, Anne. Sorry, I'm so glad this is like virtual because I was sick. And then I'm like, oh, good. I could still be here. Well, I'm super sick, but thank you, Anne. And thank you, Dr. Vaughn, for kind of really setting the stage, right? So my name is Leslie Ferber. I am the Associate Director of Advocacy Relations at Sobi. Sobi is a Swedish company based out of Sweden, and our focus is to, focus on delivering innovative treatments that improves on the standard of care that benefits the patient, society, and just as a, healthcare industry as a whole. We believe all patients should have equitable access to medicines. Our strength is to moving with urgency to create the possibility of living with rare and often severe diseases. And I think, when we kind of talk about that in the MPN space, and I love how Anne and, all of our industry partners before us kind of talking about, the access that are available. So Sobi has a JAK inhibitor called Vonjo. Some of you have probably heard of it. So and I think with the amazing science and just how things have progressed in the past 10 years, there are more than one JAK inhibitor now, and of course not all of them are the same. And this is just really the conversation of having with your doctor, kind of like, hey, finding which one is right for you. So for ours is indicated for certain myelofibrosis populations with low platelet counts. So be sure to talk to your doctor about just kind of like the difference in JAK inhibitors and all of that. But on that note, we also have our CTI access, because finding your medicine, the right medication for you is one thing, but like having access to it, it can be a totally different thing, right? So we want to really make sure that access is not going to be an issue. So we have CTI access where you can go and sign up, and then there's copay assistance as well as a gap program, if there's any way, because your financial situation shouldn't be shouldn't be a reasons for why you can't have access to a certain medication. So you can always go on to ctiaccess.com or go to vonjo.com, and then you can actually look at the access website. And lastly, I really want to thank Anne for really kind of bringing everyone together and just kind of always keeping everyone informed, because an informed population is just that much more important to have that great health outcome. And I just love how Dr. Vaughn was like, it's that shared decision making, right? It's really finding what's important for you. So thank you, Anne, for having that opportunity and just always reminding folks that we deserve better. And we can do better.
Leslie. It's true. It's very true. And Dr. Vaughn was great. And thank you for your update. And we're glad that we have these drugs available to us. And we'll be back in probably another week, I think. And I think the next webinar is with Natalie Giacondo, who is a yoga and meditation specialist. And she will be instructing you. And so join us for that. Thank you so much and have a great day.